As I said, we have an amazing lineup of 6 fantastic posters to be presented here. So I'll ask them to share their screen. And if you haven't already, please make sure that you upload your poster to Zenodo so that others can see it. We are getting lots of notices of people saying, I want to be in 3 places at once. And so can you tell me how I can get access to the parts that I'm missing? So thank you for sharing so that we can continue this conversation. And with that, let me please invite Arjun to start us off with a poster on comparing common factors between a human to a generative AI conversational agent in delivering PMT. And this is casual, so at the end of the presentation, I encourage everyone to raise your hand to ask questions or add them into chat. And yeah, look forward to turning it over to Arjun now.
Hello. Hey everyone, thank you for stopping by. This poster is an exploration of how common therapeutic factors differ when in delivering to parent management training between a conversational agent and a human therapist. So in this poster, we observed 5 conversations. One of them was between a highly trained human therapist and an authoritative parent. 4 of them were between a conversational agent known as Pat, who specializes in parent management training, and mock parents played by graduate students. So the graduate students played four different parenting styles. The 4 parenting styles are authoritative, resistant, permissive, and authoritarian. Each conversation was evaluated by graduate student raters based on 5 common factors, and those common factors that chosen were collaborating on goals, the way the conversation flows, addressing concerns, validating clients' emotions, and handling resistance. In terms of the results, we found that there was differences between Pat and the human therapists in terms of the performance, and the human therapists would perform better, but these results were not statistically significant, and this is likely due to the small sample size and the conservative nature of post-hoc tests. Still, these findings highlight areas where conversational agents could improve, especially in handling these emotional nuances and resistance more effectively. It also highlights the importance of using conversational rating tools to improve the way AI converses and potentially helps in mental health. Thank you.
Wonderful, thank you. Let's open it up for questions here. I'm happy to start us off. I'm really curious if you were to repeat it, what would you do differently to try to strengthen the effects of the conversational agent? Where do you think it sort of had met challenges?
So I think one of the areas that it met challenges was the flow of the conversation, and also kind of it was very good on collaborating on goals. It kind of like, because of the way there was an agentic structure that went into the conversational agent,
Mm-hmm.
and so it had very clear tasks that it needed to fulfill. So it kind of like got the goals very clear and made sure that the goals were met. And also because of the way it was using a ChatGPT system, and because of the way ChatGPT approaches conversations, it was doing decent on addressing concerns, and it was like ChatGPT tends to be a little bit more empathetic when talking to people. And so I think the two specific areas were conversational flow and handling resistance. It was not exactly familiar with those areas, and there was some improvement that has been happening in that area.
Yeah, that's interesting. When you say improvement in that area, do you mean sort of for the systems in general or particular to sort of the work that your team is doing?
Particular to like the work that's gone into this
Ah,
chatbot.
okay.
And using these rating systems, they've been trying to modify and make sure that it like gets better.
Yeah, yeah, yeah. No, that's great. Other questions that people want to share for Arjun or raise?
So will you talk about the common factor score, what that is?
The common therapeutic factors, are you talking about
Um,
that?
yeah, because in the results section, it said the human therapists achieve a common factor scores of, and what is that common factor score?
Oh, so this overall common factor score is, so each of these sections was graded on a Likert scale from 0 to 10. And so the score that you see over there is, because there's 5 students, so there's a total of 250. And so that's a score that's achieved when you sum everything up. And so that means like the human therapist scored 227 out of 250. So of the 5 raters, it lost 23 points amongst them
And
across
I
the different
think
sections.
maybe tell me if this is incorrect, but just so you know, Arjun, we have people of a really broad array of backgrounds. So we have folks on who are engineers and may not be as familiar with clinical psych, and people who are clinical psychologists and may not know as much on the technical side. So do you want to explain just kind of the concept of common factors in therapy and what that's referencing? Because it may not be clear to everyone.
Oh, I see. Okay. Sorry about that.
No, you're good.
So common therapeutic factors is kind of like a way that, give me a second. It's the way that you evaluate how a therapy, like how the connection between the client and the therapist is happening. And so that's what we were looking at in this poster.
That's helpful. And yeah, just so folks know, like a common way that it's discussed is that there are certain characteristics that are common to good therapy across lots of therapy modalities, like the alliance, like Arjun is talking about, things like that. Whereas there are other factors that are specific to the type of modality. So, doing exposure to emotional processes, for example, in treatment for anxiety is going to be very, part of exposure therapy and part of cognitive behavioral therapy, that you have those particular kinds of experiences where that exposure might not be as present in interpersonal therapy, but both of them are going to be related to having a strong therapeutic alliance. So the alliance is kind of a common factor, and then there are these specific therapy elements depending on the kind of therapy.
Arjun, thanks for this. I have another quick question if there's time. Okay. Can you give a little bit more context to the 5 conversations that were simulated? So was it like simulated as if this were a session that was happening with a therapist, or was it more like, oh, I'm coming in as a parent with this parenting style who's in distress in this moment of like crisis, not knowing what to do with my child who may be experiencing a very severe temper tantrum. Can you share a little bit more just about the context of those 5 conversations, how they were set up?
Okay. Yeah. So the first conversation was a publicly available conversation between a human therapist and an authoritative parent. The other 4 conversations that were simulated by Pat, so those conversations, the graduate students came in with a certain like parenting style that they wanted to do, with certain information on how they wanted to portray the parenting style, like what the kid was, what age the kid was, what the problem was, and then they went through this. This is a text-based conversation also. So they were doing this through text. So they were like doing this through the online tool, and then they were texting with the AI, and that was how it was simulated. Did that answer your question? Or
Yeah, I think I was just trying to get more info around like, yeah, was there like uh, like how did they know when to stop the conversation? Like, was it taken to the point at which the problem is resolved, or they just, continued discussing for as long as they wanted to? There weren't really like,
there were certain
limits
like
around that.
sections of PMT that were that they had to get through, and once they got through those sections, think of it as ending a session, and that was basically where it
Okay.
stopped.
Okay, cool. Thank you.
Fantastic. Great questions. We're off to a terrific start. I'm going to move us on just to make sure that we have time for everyone. So please join me, first of all, in thanking Arjun for the fantastic presentation. And excited now to welcome Lutfia, who's going to be speaking about the role of media use in adolescent identity development, parent-child conflict as a pathway.
Yeah. Was my voice clear? Yeah, perfect. So welcome everyone. Today's session. My name is Lütfiye. I'm from Turkey. This is the study when I was doing during my bachelor, but now I will be starting my doctoral studies in George Mason soon in the US. So for our study, we wanted to see the effects of actually the association between media usage and psychosocial identity development in adolescents, with a particular focus on parent-child conflict. So we had 2 questions in mind. Does extensive media usage predicts psychosocial identity developments? Are they associated? And how does can actually parent-child conflict can explain this association? So we use quantitative cross-sectional survey study, digital survey. We intended to reach 270 high schoolers between age 14 to 18. However, we are still in data collection process, so we only have the results of 56 students and parents also, because we also included parents to the survey to get the demographics and also media parenting questionnaires. So as you can see here, we had two groups: lower screen time adolescents and higher screen time adolescents, and their means for parent-adolescent conflict scale is slightly higher than the lower screen time, and also psychosocial development scores are smaller than the lower screen time, which is important. And media parenting did not really make a difference. But when we look at our preliminary findings through our correlation matrix, we see that, yes, higher media usage associated with lower identity development, and conflict between parents and adolescents is negatively related to identity formation. So children who has high parent-adolescents conflict, they scored lower in their psychosocial identity questionnaire. So this gave us an understanding that, yes, we will be running path analysis for further analysis, but it just gave us the track that we are on the nice and right track, that the parent-child conflict can mediate and explain us how does media usage affect their psychosocial identity development. But we have some limitations. We are still in data collection period, so we don't know really what it will bring us. But here we are. We only have this so far. And we also not really sure about the accuracy of the self-reported screen time data. As you well know, people report majority of the time less screen time of their. So we are not really sure, and we couldn't have the opportunity to use application tracking, something like that. But yeah, this was for me.
Fantastic. Thank you so much for sharing these interesting findings. And I think all of us have been in that situation of still collecting our data and figuring it all out. So appreciate sharing this update. Let me open it up for questions from the group. Yeah, Emma.
Thank you so much. That was a really interesting project. One of my questions, did I understand correctly that you also recruited parents in this study?
Yeah, same parents of the adolescents who joined the study.
Okay. Yeah, so one of my questions, I'm just thinking about parent-child conflict, and this is just sort of my hypothesis, is that potentially like the parents that maybe there's more conflict in the home, like maybe they would be less keen to be kind of getting involved in this kind of study. I was wondering if you of the sort of children that were approached, because I'm assuming you needed to have both the parent and the child consenting to take part. How many parents declined to take part in the study? And I'm just thinking of the implications in terms of, how it generalizes, given that there were some people who weren't selected to take part.
This was the hardest part, to be honest, to get the parents. We had to take the parents because of the age of the children. So ethical considerations. I literally went to high schoolers to explain our studies, but before that, we needed to reach the parents. So we collaborated with the principals of the high schools. So we first reached to parents to fill the questionnaire. So 156 parents plus their parents. Did I say correctly? Parents plus their children. So all of the parents needed to be involved, one of them. So it's either the father and the mother, but as you can see here, it's not really clear, but majority of the parents were mother, and the majority of the children were men, like boys, yeah.
Okay. And did you find that there were parents who opted out, like quite a lot of parents didn't want to take part in the study?
No, not really. The ones that we approached, they accepted so that we can reach children, because it's like a two-phase of study. First
Yeah.
part belongs to the parents,
Mhm.
so, and then we can get to the children.
Okay.
Of course, fathers are a bit hesitant to join. That's what we can see so far.
Okay.
But the ones that we approached, we almost got majority of them to join
Okay.
study.
Okay. Thank you.
Wonderful. And we'll do a really quick question from Stephanie to make sure we stay on time. But Stephanie, do you want to jump in?
Yeah, thank you. Thank you for a super interesting study. I was interested, I am assuming this is a cross-section study, and I guess that you probably were not able to collect or did not collect data on like early screen time use, like in earlier childhood and everything. But my guess
No, unfortunately.
is that that would have affected, I imagine that would have an influence. And I'm wondering if you knew anything about the literature about early screen time use, identity development, and how you think this may have affected it.
It definitely has
Your
an
results, that is.
effect. It would definitely have an effect, because since we are living in a digital environment, so the children are getting exposed to the screen very early ages, and it affects their socialization processes and also the academic success even. So it would probably would have an effect. So, but given the given conditions, we couldn't really reach to the information about their the early ages. But I think it would have great to see that how their, for example, 3 years of age screen use would affect their 18 years old social identity. Yeah, that would be nice to see that.
Fantastic. Well, thank you so much. And I appreciated Stephanie's question of also highlighting the timing piece, because it'd be also interesting to look at, is it that families that have a lot of conflict that children withdraw and spend a lot of time on screens, right? We have an interesting kind of directional question here that is super fascinating. So a big thank you to Lifia for the fantastic presentation. And now I'm excited to turn it over to Bianca, who's going to talk about how within-person changes in mood relate to qualitatively anomalous phone use in adolescents, a pilot study.
Great. Thank you. Looks okay? Everyone can see?
It's just coming in.
Okay.
Got it.
Awesome. Okay. Hi, everyone. I'm Bianca, and the project I'll be presenting on explored how within-person changes in mood might relate to qualitatively anomalous phone use in adolescents. For some background, research on screen time in adolescent mental health often lacks nuance beyond how much time adolescents spend using their phone in a very general sense. Many researchers are now integrating EMA, as I'm sure you know, but in case you don't, this involves pinging participants for surveys multiple times throughout the day. This method helps us better understand the context around adolescents' emotions and their phone use. In particular, anomalous or also known as atypical phone use might be especially meaningful when we're trying to understand how mental health might relate to phone use. And by anomalous, I mean phone use that is different from what a participant usually will do. And this might represent a deviation from participants' usual emotions. So the current study collected EMA data from 8 adolescent pilot participants. Each day of EMA data collection, they received 3 surveys asking about their momentary emotion and phone use in the past hour on a 0 to 100 scale. For phone use in the past hour, 100 represents very typical use. We use linear mixed effects models to test how within-person changes and emotions related to whether they rated their recent phone use as more typical or atypical with this sample. And this approach can help us disentangle within and between person effects. Out of all the emotion-related variables that we tested, which you can see listed on my poster, only adolescents pilots momentary loneliness related to ratings of atypical phone use. So that means when pilots felt lonelier than usual, they reported that their phone use was less typical. So this finding suggests that there may be something unique about loneliness and how it affects or reflects changes in digital behavior, as other emotion ratings were not associated with ratings of typicality of phone use. So I have some future directions described on my poster, but for the sake of time, I'll end there. So happy to answer any questions. Thank you.
Super interesting work. Let's open it up for questions.
Thank you so much. I have a quick question. Can you describe a little bit more about the feasibility of the study? Because I also in the process designing like ecological monitoring assessment focusing on adolescents. And so they have to have the phone and then you're gonna send the notification to them. Will that bother them too much? And what is the way that you prevent for retention to make sure that they fill in the questionnaire in a time that you wanted to have their data in. Yeah, I want to know what are the approaches here.
I think many people in this area of research can definitely relate to that sentiment, and we are like actively working on how we can like best get participants to comply to EMA as much as we can, but adolescents in particular, as I'm sure many of you know, are a bit of a difficult population to get to answer these surveys. But that's why we're kind of like working through launching our study by doing this pilot version to see how we can best encourage participants finishing these surveys. So one thing that's been helpful, and our teen advisory council was very helpful in implementing this, was adding like a streak into the app. So that kind of like encourages participants to continue answering surveys to like keep up their streak, kind of like a Snapchat streak. We're also planning on integrating a bonus for when participants complete like a certain threshold of surveys in a week. But yeah, we're really like trying to think through that specific question right now, since this is all like to launch an 8-month version of this study where they will be like having EMA bursts throughout. So yeah, something we're thinking about through actively. Thank you.
What is missing data what is current missing data rate?
It's a great question. I didn't include that in here because since this is more like pilot data, we kind of were like on and off with surveys depending on what we were testing at the time. So I can't exactly answer like missingness for this particular data set, but would be happy to like follow up on that if you were interested in reaching out again. Yeah.
Fantastic. We only have about a minute left, so I'm going to turn to Sarah's question in chat, and then Sharon, if you want to add your question to chat so Bianca can follow up, that would be awesome. Sarah's asking if you can give some examples of what atypical may look like and how that was determined.
Yeah. So since this is just based on their reports, we kind of explain it to them as using a different app at a different time than usual, using an app like a lot more or a lot less, but it can kind of depend on the participant because this is like their own self-report, but this is where we want to like integrate our algorithm, which my team is working on in launching our new study. Into being able to determine like exactly what is anomalous and still something we're thinking through. So thank you.
Fantastic. Great questions. And it looks like you've got other questions coming in through chat. So please follow up on those. And everybody join me in thanking Bianca for a really thought-provoking presentation. And excited now to turn to Emma, who's going to be talking about examining openness to donating personal data from digital devices for mental health research among college students.
Everyone just moving the screen around. As much as I practiced it earlier, it always seems to do something different when you're actually in the moment. Okay, hopefully you can all see me okay. So can you see the screen as well? Just check. Cool, great. Nice to speak to you all today. So yeah, the talk presenting today is looking at basically how young people feel about sharing their data for mental health research. So as you know, young people use their digital devices for many aspects of their lives, and these devices can provide a lot of insight into their mental health. But thinking about, some of the ethical and the technical implications of asking young people to share their digital data for research, it's really important for us to understand what they think and feel about sharing this data. So in this particular study, we asked incoming psychology students at the University of Virginia to rate how comfortable they feel sharing 9 different types of data in 4 different scenarios for health research. So data types included Google searches, GPS location, web browser history, 4 social media types, so that's Instagram, YouTube, Facebook, and TikTok, and their emails and their texts. And we also asked them how they would feel about sharing these data types across 4 different scenarios. So in all these 4 scenarios, participants were told this data would be shared with UVA researchers, and additionally, it could either be with a public database, a limited set of researchers. The third scenario would be giving them the option to choose what data gets shared. And the final option would be only sharing summary statistics, such as number of likes or screen time, rather than the content of their messages. So in the study, we had 345 participants, and we undertook some exploratory ANOVAs with post-hoc Tukey's t-tests and calculated Cohen's d effect sizes. So turning to the results, I guess the main takeaway, which is something which is quite positive, I think, is that 67% of the college students in our sample felt comfortable sharing at least one data type in one of the 4 scenarios. So the graph in the middle, which is going to be way too small for you to see right now, but you can revisit online. It's been uploaded. Essentially, the graph in the middle is showing the mean and standard deviation for the comfort levels for sharing each of the 9 data types, and the 4 horizontal lines are representing who the data would be shared with. So just to note, the scale is reverse scored. So a score of 1 indicates feeling very comfortable with sharing this particular data type, and a score of 5 is very uncomfortable. We found that there was variability in the levels of comfort depending on how the data would be processed and who it would be shared with. And commonly, participants felt more comfortable sharing with their UVA researchers if it would be for sort of summary statistics compared with sort of sharing something that would be more publicly shared. And they felt more comfortable sharing sort of Google and, interestingly, their social media data than they did their email and texts. GPS and web browsing was kind of in between these data types in terms of comfort levels. And I think notably, like the effect sizes were kind of largest for comparisons with text message data. So we found that this was particularly something that was making people feel more uncomfortable. And then just sort of briefly, like summary and next steps. It's important for us to consider when we're asking young people to share their data for research, sort of what's being shared, how it's being processed, and who it's shared with. Limitations of this was a fairly homogeneous sample of psychology students who might be more willing to share this kind of data than the general public. And future research want to look a little bit more deeply in kind of some of the nuances around whether certain demographic groups maybe have more or less comfort with sharing data. So apologies if I went over time, lost track of my timers, but please welcome any questions.
Fantastic. All right, let's open it up for, probably have time for 1 or 2 questions.
I have a question. I think this is really interesting. I just returned back from a data sharing, data management workshop, and we talk a lot about, open access and how, for sure to, from the very beginning to organize the projects in a way that ready to be shared. And, with other researchers, I think your research definitely providing promising in a way that actually participants do wanted to share their data in the way that's they for sure can contribute on the science, but and at the same time that their privacy can somehow be got protected. But my question is, right now I'm thinking about the way for collecting the social media use is through the screenomy. I don't know if any of you familiar with this, and I'm kind of just learning through this process, like kind of get continuous like screen kind of like screen data from participants, like collect data every 5 seconds, stuff like that. But I know that's very sensitive. And that will be a way for, like share that data for the future. But I think, yeah, so I just don't know how people will be open to that, but for sure, like can under some sort of protection technique that's, other researchers can also continue to use the data sets for use these things as well if participants are not going to be opt out because they contain a lot of sensitive information.
Yeah, absolutely. Yeah, and I think just very briefly, I mean, this is an area that I think had some discussions around recently, and we haven't asked that question yet. I think if in terms of screenomics and trying to get sort of patients on board with sharing that kind of data, I think there was going to be a lot of work in kind of defining what screenomics is and what it actually means and who is it going to be shared with, because I think the more intrusive it becomes, the more sort of, really need to explain the protections around kind of what data, what's going to happen with their data. So that's a whole other conversation, but I'm really interested in that as well. And thank you for your question. I wish you luck with your research in this as well.
Fantastic. And Emma, you have some questions coming in chat that I know you've done some analyses on, so you can easily answer, which is fantastic. And to the earlier question, Jaron Sun actually presented on the screenomics approach in one of the Ask an Expert sessions earlier, and she's actually consulting with us for a project, and it includes a qualitative part with adolescents to talk about how they feel about donating the data in that way and what their comfort level is. So I'm 100% with you on those pieces.
That's interesting.
Yeah.
I have to find the recording.
Great. All right. So please go ahead, Emma, and answer the questions in chat. And if everyone can join me in thanking Emma for a super interesting presentation. And now I'm excited to turn it over to Jacqueline, who's going to talk about leveraging digital single session interventions for adolescent trauma-focused services.
Can everyone see my screen and hear me? Awesome. So today I'm going to discuss Renew and how we developed a digital single session intervention for adolescent focused services. To give a little bit of context, adversity experiences in adolescents are both harmful and frequent. And schools, as the primary mental health providers for adolescents, are mandated to be trauma informed. This means that they must be able to recognize trauma symptoms, intervene when adolescents are experiencing trauma-related distress, and prevent re-victimization from occurring. However, there's many implementation challenges that come with implementing trauma-focused interventions. School-based clinicians lack sufficient training and confidence. There's also a lot of high turnover within school mental health staff. There's also low therapy engagement with adolescents and difficulty triaging youth in high adversity communities. Digital single-session interventions are able to promote youth therapy engagement. They also ensure that evidence-based treatment dosages are given to those who are most in need of services. It also allows for schools to have a shared socio-emotional learning language within their schools providing trauma-informed care. Now I'm going to introduce you more to the prototype that we developed, Renew. Renew is a free web-based, evidence-based digital trauma-informed single-session intervention. And the goal of Renew is to ensure access to mental health care, minimize trauma-related distress, and promote therapy engagement. Renew is rooted in cognitive behavioral principles, as you can see on the screen below, and these are some screenshots from the actual intervention itself. And so you might be wondering what is different about Renew. Renew provides simultaneous assessment and interactive therapeutic tools. And at the end of Renew, after adolescents input different information, it creates a digital summary for counselors, which can help with building rapport and the therapeutic alliance. For example, what's in this summary is the student's top problem, both positive and negative events in their life, the adolescent support system, as well as different coping strategies that they've tried throughout the intervention that they liked or that they didn't like. Our current and future directions include we're in the process of receiving community feedback from stakeholders right now. What we will do after that is then edit the prototype to meet the community's needs. And then after we edit the prototype, we are planning on conducting a pilot trial with a sample of adolescents to test Renew's engagement with therapy. Thank you, everyone, and feel free to put any comments that you have in the chat or questions for me about Renew, and I'm more than happy to answer them for you.
Fabulous. Thank you so much, Jacqueline. Let's open it up for some questions. All right, Gina.
This is probably one of my favorite topics, so thank you so much, Jacqueline, for presenting today. I was curious about, I have a couple of questions. One, would love to learn more about what assessments you all are doing, and love that the feedback goes to the counselors. Also curious about feedback to users and what that might look like. It's definitely something that we are looking at Kooth in a variety of ways, and is always on our radar on how we can do that in more engaging ways. So would love to learn from you, Jacqueline.
Yes. So when we initially had designed Renew, we were hoping that it could be attached to kind of the universal trauma screenings that were with it for adolescents that are required and state like mandated. But what we're currently doing is that we're hoping, I don't know if you're familiar with the multi-tier systems of support within schools, but we're hoping that this is going to be kind of a small group intervention. And that's something that that a counselor would use in the suite to be able to kind of assess some of the most I guess their top problems, as well as the different maybe negative events in their life that they may not be necessarily ready to talk about or that they may be ready to talk about. And then can you remind me about the second part of your question?
Yes, and absolutely familiar with MTSS. And I'll probably touch base with you following all of this because there might be some opportunities to collaborate there. But my second question was, what kind of feedback would the user see? So will there be any either on-screen or email or notifications in terms of the results of their assessment for MTSS?
Yes. So what we have as options is that the adolescent will get a copy of what they have input into Renew. And they have the option to opt in and to opt out of different things that they want to tell their counselor, as well as sending it to their parent or caregiver as well. So we wanted to give adolescents the autonomy there. So they are able to see all of their answers, but then they are able to choose what they are comfortable with sharing with. So they can hide their responses so that later on in future therapy sessions, they're able to unhide it and talk about it with a counselor if they'd like to, or keep it private.
It's a super nice feature. Go ahead, please.
I have a quick question about the simultaneous assessment and interactive, the therapeutic tool. So is that the therapeutic tool will responding very quickly toward the simultaneous assessment? And yeah, what is the purpose for the assessment, and then how that interactive therapeutic tool is responding to the assessments, and how frequent is assessment?
So this is supposed to be over one session, but we are also looking at ideas of having this tool be used across 3 different sessions, just because we, based off of the literature, sometimes it might be more helpful for adolescents to not just bring up trauma once, and that kind of have a therapist there to be able to kind of guide them through talking about different traumatic events. But for the assessment piece, we are kind of collecting information about, as I mentioned earlier, about positive and negative events. And we're also seeing whether we're asking follow-up kind of questions, whether they like talking about those things and whether they don't like talking about these things. The goal of Renew is to be more of a rapport building tool, as well as to be able to kind of create a narrative of kind of what positive and negative events are in their lives. So does that answer your question?
Yeah, I think my question just like, when you got that assessment, how you're going to use it, and for the therapeutic function.
The goal of it is for counselors to be able to use so that they are more prepared when going into future sessions with that adolescent.
Fantastic. Thank you so much. Jacqueline, you've got at least one question coming in the chat there to share the QR code. And again, everybody, please join me in thanking Jacqueline for that fantastic talk. And last but not least, very excited to turn to Gina Mitch, who's going to talk with us about expanding access to digital mental health, findings from Soluna's first year of a statewide implementation.
Great, thank you so much. This has been really wonderful to be a part of so many presentations today and getting to learn from each of you as well. I'm excited to share some very early insights from Soluna's first year as California's state digital mental health platform for youth aged 13 to 25. The platform is funded by the Department of Healthcare Services as a part of CalHOPE, and then also the California Youth Behavioral Health Initiative. As a part of our early evaluation, we decided to develop a survey, which we call Stellar, which is informed by the California Youth Satisfaction Survey. And while we weren't really aiming for a perfect alignment, we definitely were intentional in designing Stellar with the YSS in mind, recognizing the importance of getting early consumer feedback about mental health services and making sure to align with what the youth are interested in. We also really feel like this is important for DHCS as well, to make sure that the youth voice is essential and not an option. And so within this poster, you'll see a bit of data here, but we wanted to make sure that we weren't just looking at satisfaction. We thought it was really important to look at some early outcomes. And so within Stellar, we included questions about knowledge, skills, and behaviors that we feel are determining change mechanisms and factors that would go on to influence and reduce symptoms as well as improve functioning. The focus on early change, like knowing where to get help or realizing you're not alone or being able to connect with others, helps us capture some really meaningful impact beyond just symptom reduction. And the results have been really encouraging so far. Scroll down so you can see a little bit better. 97% said they'd recommend Soluna to a friend. 80% reported feeling more connected and better equipped to cope. And lastly, and just a really big shout out in terms of prevention and early intervention, 74% learned more about where to seek help when they were needing it, and demonstrating just the value of that prevention and early intervention. So take a moment, take a snap of the QR code. If it doesn't work, let me know, and I'll put the link within the chat as well too. And also keep an eye out for our impact page on Soluna for an upcoming published report on our 2024 evaluation, as well as a couple of papers that we'll be publishing in terms of manuscripts. Thank you again.
Fantastic. Let's open it up for questions. And do you mind, just scrolling up so people can see the top again? Perfect. Thank you. While others are putting their thoughts together, I wonder if you can talk a little bit more about the range of implementation pathways you sort of were using here, because it's, it's such a large potential sample in that way. And I'm curious how you approach that.
Absolutely. So Soluna is population-based, and that means in terms of marketing, we are marketing through exhaustive social media forums, as well as in-person events, everything from going into schools directly, connecting with behavioral health programs in California, to large events around holidays and just special times of the year. And so it's very broad in terms of implementation. I can't say within our first year, as the last time I looked, we had over 90,000 users engaging with Soluna,
Wow.
which we're really excited about. And again, part of this is we really felt like it was important to implement a specific survey that allowed us to glean some things beyond just the typical PHQ-8 GAD-7. And so this Stellar survey allowed us to do that. And I'm happy to take questions on what kind of questions, especially to provide resources for anyone that's looking at how do we collect data, or what do we collect beyond looking at functionality and the symptoms.
Fantastic. Other questions people want to raise?
Yeah, I'd love to learn a little bit more about your perspective on some of the features that you feel like have really stood out in trying to increase engagement for youth.
Yeah, happy to do that. We're definitely going to have some more that is going to come out of this as well too. I should have mentioned that we are single session oriented, so much of what the users are engaging with are single session drop-in chats, but we're also finding that there is a lot of usage of both of our tools and content. So there are a number of tools within Soluna that focus on different aspects of psychological flexibility. So we have some breath work, let it out tools, journaling, mood log, a variety of tools. And so we are seeing as a combination of that single session intervention, along with utilizing quite a bit of those tools. And then in June of last year, we were able to implement care navigation, which is an area that we're continuing to develop, but we felt like it was really important that for those users that have a higher level of need and would need something outside of a single session, would be able to be connected with care navigators who can directly connect them to affiliated network partners that we have within California to get those extra services and supports. And so just in 2024, we had about 100 users who engaged us with that particular care navigation as well as the other tools. We're expecting to see that increase as time goes on as well too.
And what are you seeing in terms of groups that you feel like, I mean, 90,000 is an enormous sample. And I'm curious to hear though, like, I assume it's not evenly distributed or perfectly representative of the population. So what are you seeing in terms of like, who's most drawn to this and where it's been harder to engage folks?
Sure. Bethany, you would actually be surprised. It's a pretty diverse population. One of the things that we did within our engagement team early on that was really unique is we utilized the Healthy Places Index for California to take a look at the counties throughout California in terms of what each county's needs were. And we prioritized, of course, we did social media across all of California, but we prioritized the top 10, or I should say the bottom 10 Healthy Places Index counties to do specific promotion. And so as the data is pouring in, we're actually seeing that we're over-indexing in terms of Central California. So we're pretty excited about that rural, as well as with the BIPOC. And we're also seeing an over-indexing on those that are identifying with a gender other than cisgender male or female. So we're excited about being able to connect with, and some of our really great stories have been around how the content is really personal, especially coming up with diversity and inclusion, and being able to really hone in on some of those topics that they feel like they're comfortable sharing about and connecting on.
Fantastic. We have just about a minute left. Is there a final short question that people want to share either for Gina or for others? And it looks like there was one maybe in chat there about how youth are identified that you partly covered though, I think already. Wonderful. Well, let me take this time then to just wrap up and thank the group for an amazing set of presentations, and also thank you to attendees for a fascinating set of questions. I really appreciated everybody jumping in and the rich conversation. And from following along in the chat, it looks like all kinds of connections have been made, and hope people will be able to continue the conversation afterwards. So thank you, everybody. And I want to encourage you to go to either the grad school open house if you're at an earlier stage, or to the virtual exhibit to see some of the new innovations that are coming up. Thank you all. I really appreciate it.
Thanks, everyone.